This program is intended for informational purposes only and does not contain medical advice. As always, please contact your physician or qualified healthcare provider with any questions regarding a medical condition. Hot and Bothered podcast. Welcome to another episode of Hot and Bothered with Melyssa Ford. Before I introduce my esteemed guest, I want to tell you guys a little story. So I moved to New Jersey in 2023, and the first priority that I had was getting myself set up with a healthcare plan and finding myself doctors, a general practitioner, gynecologist, the whole nine. So I found myself a GP. He is a wonderful doctor. His name is Dr. Andrew Fagelman. And the first thing that we did was, we wanted to create a baseline. So we started by taking blood work, and he took some family history, to which I don't really know much. Most of you know that both my parents aren't alive anymore. None of my grandparents are here. My family history is a little, murky and mysterious. So basically all we have to go off of is what I can report to him in terms of my current health, my past health, and also creating a baseline with my blood work. So what we discovered was overall I was really healthy, but my cholesterol level was really high. And this is something that I wasn't familiar with because I'd never been told that my cholesterol was high. But in doing some research, I've come to find out that it seems to be a symptom of perimenopause. A lot of women are starting to see their cholesterol levels rise, and I don't really think that doctors know the real reason why. There's speculation, there's theory, but since menopause is still kind of like an iceberg, you only see this little bit, and a lot of the information is under the surface and yet to be discovered. It's still up in the air as to what the reasons were. So we decided to monitor it over the course of about a year and a half. And so every 6 months, I would come in for whatever reason, and I would always get blood work done. And in monitoring my cholesterol, we would also, discuss maybe some lifestyle changes. Everybody knows I'm very healthy. I work out a lot. I eat well. I have an 80-20 rule. 80% of the time I'm eating really well. 20%, I kind of go balls to the wall with sugar and salt and whatever. But it's balanced. And what we noticed that even though I reduced, eating red meat, I reduced eating egg yolks, I upped my cardio, my cholesterol levels continued to rise. And so my doctor, being the amazing doctor that he is, who listened to me, decided to send me for something called a CT calcium scan. I was completely unaware as to what that was. I'm still in the, learning phase as to the screenings that we start to have to do as we venture into, middle age in our older years. Don't want to, call myself old just yet, but I sure as hell feel that way sometimes. So he sent me for a CT calcium scan, which basically meant that I was stuck into an MRI machine with, these electrodes hooked up to my chest. It took about 3 minutes, didn't hurt at all whatsoever. And what he wanted to do was he wanted to find out how much plaque had calcified in the arteries in my heart. And so when he got the results back, he said, Melyssa, I was actually quite surprised by how much plaque had calcified in the arteries of your heart. And I have to put you on statins right away. And I will let my guests tell you what statins are, but all I know is that I cried for the next 24 hours because I, at that moment, felt like no matter what I did, that there was an element of my health that I could not control. I worked out, I ate healthy, I quote unquote followed all the rules as to what you're supposed to do to lead a long, healthy life, and then this happened, and I didn't have the answers for it. So I was put on statins, which is cholesterol medication, and I've been taking them maybe for the last year. And I haven't really noticed any differences in my health other than the fact that my doctor says that things seem to be going well. So with that being said, I decided that I wanted to have an episode devoted strictly to heart health and also the awareness around cardiovascular disease, which is the #1 killer of both men and women. And so, what I wanted to do also is I wanted to put a strong focus on men's heart health in this episode. So, I'm going to introduce you to my guest right now. I'm sitting with Dr. Alain Vaval. Hi, Alan.
Melyssa.
Thank you so much for joining me.
Thank you for having me.
Alan is a board certified internist and cardiologist. He has been in practice for over 13 years and he has joined me, and I'm so excited because he never does this. He really does not he likes to play the background. As handsome as he is, he likes to play the background, but he's going to basically just give us a whole lot of free medical advice today, and we could sure as hell use it considering what, healthcare prices are like these days. So, you were actually able to see what my charts look like.
Yeah.
Tell me what you saw when I showed you my charts as it related to my cholesterol level, as it related to the results of the CT calcium scan, and then what my doctor ended up, doing in terms of prescribing the statins for me.
Yeah, perfect. So, as you mentioned, I did look at your lipid profile, your labs, and your calcium score. And, I think your doctor did all of the right things. I'm really happy to see that he did this because there are many, this message has not gotten out as widely as we'd like to see.
Mhm.
When we see patients, sometimes, you can't judge a book by its cover. Like you said, you've done everything you're supposed to do. You work out, you eat right, you exercise, you went to see your doctor, and your doctor did appropriate screening. And I think that's really important. He screened you first by getting a lipid profile. And we know that atherogenic lipids or fatty lipids
Mhm.
are the basis for plaque formation in heart
What does
arteries.
lipid mean?
So,
Because like when we get with the medical jargon, sometimes people's eyes glaze over. They're like, "See, this is why I don't go to doctors." You know what I'm saying? Because I don't understand. So I
yeah.
want to try to kind of give the audience layman's terms when it comes to kind of medical jargon. So what is a
No problem.
lipid?
So a lipid in a word is, I mean, in a few words, is a fat particle.
Okay.
And there's some fat particles that help to remove other fat particles, or there's some smaller fat particles that sort of get lodged in the walls of your arteries.
Hmm.
And our body makes fat.
Hmm.
Our liver makes fat, and it makes these lipid particles or these fat particles. And there's different types of lipids or lipid fat particles. And depending on the composition of your fat particles, you have a higher risk of starting to develop these plaques that will eventually, one, narrow your arteries, and or two, rupture and cause clots to form in your arteries. And that's what forms the basis of a heart attack.
Hmm.
Um, so, when we see, like if I took the lipid profile or the fat particle profile of a 15-year-old kid, I'd
Hmm.
probably see an LDL cholesterol of less than 70,
Okay.
maybe even less than 50.
What's my LDL?
Your LDL cholesterol is 166.
That high?
It is.
What's normal for an adult in their
Normal
40s
adult,
who's doing really well?
depends on the lab, but normal adults usually around below 130. Um, we'd like to see numbers below 100.
Hmm.
We certainly know that above 130, you start laying down plaque in the arteries.
Hmm.
And so the goal is to keep you from developing levels that are that high, either with diet or exercise or with drugs if we need to. So the idea is if when we see lipid profiles of 166, we know that you're starting to lay down plaque.
Hmm.
We know that you have enough fat particles floating around in the bloodstream that will accumulate in the arteries or the walls of your arteries.
Okay.
So I brought a model to explain this. Okay, so this is a model of your heart,
Okay.
and these are the pipes or the arteries that supply blood to the heart muscle so that it can perform its function and squeeze.
Okay. So what's that? Ventricle?
So,
See, I'm trying to be smart, right?
so,
But I don't
so
know that.
this is actually the inferior vena cava. This is a vein, but they left it clear
Yeah.
in this model
Yeah.
so they could just show you the arteries. So
Okay.
so your heart has one major artery that leaves it called the aorta,
Mm-hmm.
and it fills the muscle of the heart through these things called coronary arteries. And these are the arteries that supply blood to the heart muscle so that it can squeeze and perform its job.
Okay.
All right.
Okay.
And so if we took one of these arteries and we
Mm-hmm.
zoomed in on it,
Mm-hmm.
it would look like this. And this
Yeah.
would be a normal artery.
Mm-hmm.
And this artery would have three layers: an inner skin layer, a middle muscle layer, and an outer skin layer.
Okay.
And over time, if your cholesterol levels are high, you start to develop these fatty deposits along the vessel wall called fatty streaks. And as you begin to lay down more and more and more and more fatty particles, these these streaks can become actual blockages
Mm-hmm.
and narrow the diameter or the lumen of the artery.
Mm-hmm.
Okay. And so
That looks like it's pretty severe.
yeah, yeah.
Mhm.
And so you can get narrowing. So this would be, in my estimation, about an 80% lesion or so. And if you had this problem, you might find symptoms when you exerted yourself. So your pipe is supposed to be normally this diameter.
Mhm.
And then with disease, it's now 80% lower in diameter. So it can carry less blood.
So by looking at my chart, would you say that I'm the third one?
Well, no,
Okay.
no. So your test was a test that was designed to understand, do you have any plaques or not?
Mm-hmm.
And the more and more we understand that test, even that is not entirely perfect. So your test is really designed to say, is Melyssa at a higher risk than people in her age group? Or is she at a lower risk than people in her age group?
Mm-hmm.
And one of the reasons why your doctor, um, when finding the results of the calcium score, said, I want to start you on a statin, is because your score is higher than one would expect for your age group in age adjusted women. So the calcium score is adjusted for your cohort. So, you know, women in your age group, 5 years, on either side would get a score, and then you would get a percentile rank based on the people in your age group and
Mm-hmm.
sex.
Mm-hmm.
So that's how it works, and it lets us know it's really a yes or no test. Is Melyssa somebody we should worry about and do more testing on and get more aggressive with risk factor control, or is Melyssa somebody who she's lower risk and she's less likely to have a problem?
Mm-hmm.
And so that's what that test helps us to understand.
So by looking at my test, and then I want to start talking about, diet, prevention, screenings, monitoring, and that whole thing, and also addressing why men seem to be very, averse to going to the doctor, and how we can kind of reframe the way that they think about doctors' visits, and advocating for themselves and empowering themselves when it does come to going to the doctor. But by looking at my numbers, if my doctor had not put me on the medication, what what does that say? Like, what did the horizon look like?
Well, I'm glad you asked that. So the reason why we focus on prevention now in cardiology, like I really think most good cardiologists should, and internists for that matter, should focus on preventing disease, because once disease comes, it's harder to deal with some of the downstream consequences. But by focusing on prevention, we can say you have this high lipid score, this LDL cholesterol, and that LDL cholesterol is making you accumulate plaque in your arteries faster than your peer cohort. And so by lowering that cholesterol, or lowering that LDL cholesterol in particular, because that's the type of cholesterol that's most associated with heart attacks, strokes, and plaque progression. By lowering that number, we can slow down the progression and hopefully arrest the progression.
Mm.
All right.
Okay. All right. So let's talk about screenings then, because I didn't even know that this type of screening even existed. And I'm grateful that my doctor had the wherewithal to not just say, well, women in perimenopause, it seems to be a symptom of such that cholesterol levels are going up, and it's not really indicative of anything. So, pat me on the head and scoot me out the door. He was a lot more proactive. So I'm really blessed to have him as my doctor, because he actually listens to my concerns and we come up with a game plan together. So when it comes to screenings, at what age should Black men start to begin regular heart screenings, and what does that look like besides the CT calcium scan?
That's a really
And
good
is that
question.
the starter one, or can you? Yeah.
So that's a really good question. So the the screening of heart disease really happens at any wellness visit, and so this is where because although coronary artery disease is one type of heart disease, there are other types of heart disease. Your heart can become weakened, it can fail, it can become stiffened or fibrotic, it can become electrically unstable, and you can start to have rhythm disturbances. So there's a lot of things that we do as doctors in visits to screen people for disease. And so I'm a big advocate of the spoken wheel model with a primary care doctor at this, at the center of the wheel.
What's a spoken wheel?
So the spoken wheel model is sort of you have a primary care doctor who assesses you for wellness, but also recommends age appropriate screening tests. So for example, I had a family history of colon cancer. So I was recommended for screening colonoscopies earlier than
Same.
the average patient. And and there are a myriad of other things: breast cancer screening, prostate cancer screening, coronary disease screening. And there's a primary care doctor is keyed in on not only maintaining wellness, so talking to you about your diet, and should be talking to you about mental health and making sure you're observing healthy lifestyles and making sure you get referred for the age appropriate screening. And so the idea is that if we can find the right people to screen at the right time, we can prevent disease before it happens. So that's the role of so that's the center of the wheel. And then if they see abnormalities, like for example, a really high calcium score, right? And now they're unsure about what does the data show for further testing. What's the right test for Melyssa? Then they can refer you to a cardiologist, and that cardiologist can say, well, the latest data suggests X, or the latest data suggests Y, and that changes. It's a little bit of a moving target, but over time we get a better understanding of how best to practice medicine.
What tests do you think what tests should be included in a routine health checkup?
So depends on the age of the patient, depends on what the patient's coming in reporting in terms of symptoms, and depends on family history and other things. So it's a little bit of a tough question to answer. But in general,
should cholesterol, blood pressure, and glucose levels be checked at every visit to the doctor?
So in most adults, the answer to that is yes.
Okay.
Lipid profile as a screening test is recommended for every adult over the age of 35, 40. And if you have familial disease, it's even recommended earlier. Or if you have evidence of disease in the cardiovascular system, it's recommended earlier. So yes, that should be done for every adult for whom there's a suspicion of heart disease.
So let's talk about prevention and lifestyle. There's a lot of, I guess, diets and whatever else. There's vegan, there's Mediterranean, there's keto, there's paleo, there is I don't care, I'm just eating whatever I want to eat kind of thing. But what diet is most effective for preventing heart disease in Black men? And also, how bad is alcohol? Because some doctors say don't drink it at all, like completely don't drink it ever. And some doctors will say, well, moderately, maybe 1 drink a week is okay, or 3 drinks a week, or whatever the case is. But what's your thoughts on that?
So I'm so glad you asked. So I have a close personal friend who has a weak heart, and asked me the similar question yesterday, in fact. And he is under the care of a cardiologist for his weak heart. And he said to me, well, my doctor said I could have a drink once in a while. And my answer to him was, no, you can't. we know alcohol is a cardiac toxin. There's no doubt about it. What we don't know is why some people behave more dramatically to the effects of alcohol than others. So some patients, they'll have a drink or two and they can develop heart dysfunction from that. Other patients can have, a fifth of liquor and they won't develop any heart dysfunction.
Can you describe like how alcohol affects your heart?
So it's directly toxic to heart cells and it causes heart cell death. We
Okay.
know that. If you like, we see acute alcohol intoxication cause things like weakened heart muscles. We see it cause rhythm disorders, both of the top chambers of the heart and the bottom chambers of the heart. So alcohol is a known cardiac toxin that causes heart dysfunction of the conduction system, of the contractile system, meaning so it causes electrical dysfunction and mechanical dysfunction of the heart. What we don't know is that there are some people who are chronic alcoholics and their hearts are healthy. It's just like there's some smokers who smoked for 40 years and they
Never developed lung
never
cancer.
developed lung cancer or never developed heart disease. But I would say you're one of the lucky ones, right? And so if if a patient has heart disease or is concerned about developing heart disease, I certainly would say um, avoid excessive drinking, and that's defined as like more than 4 ounces of alcohol a day for a man for a woman, and um, or more than one alcoholic beverage for a woman and more than two alcoholic beverages for a man.
People are definitely going to want to know, is there certain types of alcohol that's worse than others, or is just anything with an alcohol content?
I don't know the answer to that, but what I would say is, I think that red wine has traditionally been thought of as, heart healthy.
Antioxidants.
Right.
Yep. That's what we tell ourselves. Yeah.
But
When we
certainly
take a bottle to the
right,
head.
if you had a bottle of wine, I think that would probably be cardiac toxic. So, what I would say is for patients who have existing heart disease, particularly a weak heart or a rhythm disorder, I would say avoid alcohol at all.
Okay.
Most doctors don't say that to patients because they don't want to scare people away. Alcohol is quite addictive and people
Like it.
like it,
Yeah.
and they may not go back to their doctor after getting that advice. But the truth is that there's only potential harm and no potential benefit. So I often, and same thing with smoking. Like if people smoke, I tell them don't inhale anything into your lungs that's not fresh air, because along with the toxic effects of alcohol and tobacco, inflammation is a huge problem for a myriad of diseases, but heart disease in particular, because inflammation is what sort of turns on or accelerates the progression of those plaques. So if you have high cholesterol and you have an inflammatory sort of baseline, you're more likely to put those fatty lipids into the walls. And that's the way I tell my patients sometimes. It's like it's like when your kid is cleaning their room and shoving everything under their bed. That's what the inflammatory cells are doing. They're grabbing all of the fat particles that are floating around in your blood in high number, and then they're shoving it into the vessel wall and doing it in a very disorganized way. So those fatty deposits in the wall can be very unstable and it can suddenly rupture and cause a clot. And so you can go from having a vessel that's open to having a vessel that's closed suddenly because you have this really unstable fat deposit in your vessel. And that's what a heart attack is. It's a sudden popping of that plaque, and you go from having a vessel that's open to a vessel that's totally closed and not providing any blood to the heart muscle.
And that can happen just
in an instant.
Wow. Okay. Going back to the diet, as a cardiologist, what is your favorite, diet or, kind of lifestyle for people to follow in terms of what they consume, the food that they consume?
To that same vein, non-inflammatory foods.
What does that look like?
What do I mean by that? Foods that are high in saturated fat and trans fat are highly inflammatory.
So like fried foods.
Yep.
Okay.
So I try to tell people avoid them if possible, and you're going to enjoy things, but less is always better than more. It shouldn't form the staple of your diet. But foods that are very high in and preservatives.
So that would be like charcuterie boards, like
Yeah,
the
cured meats.
cured
And,
meats.
yep, yep. And they're also very high in sodium. Those types of foods, so they cause water retention and higher blood pressures. Um, uh, so fresh fruits, vegetables. Lean meats. Avoid the dripping, like the gravy, so to speak. The sauces that go on.
The good stuff. Yeah.
I'm from a West Indian background. The sauces that go on rice, and on meats, those things I would leave to the side. The lean cuts of meat are better. Um, Fish oils are better. I would avoid seed oils, so like canola oil or sunflower oil. I would prefer using things like olive oil or avocado oil.
High fiber.
High fiber, so whole grain, whole wheat bread. Um, Less sugar. I mean, I think we take in way too much sugar in general, and I would avoid things with high fructose corn syrup like sodas and artificial juices and stuff like that. Like that stuff, I would just completely eliminate.
Okay. So how much exercise is needed to maintain a healthy heart? And, is there specific lifestyle changes that can have a greater impact for Black men?
So the American Heart Association and the American College of Cardiology, they actually have formal recommendations on this. So the recommended amount of exercise for an adult male would be like 150 minutes of cardiovascular exercise a week. And so I tend to tell my patients to break that up into at least 30 minutes a day, 5 times a week, which is the basic, right? So
That's baseline, guys.
Right,
That's the bare minimum. I know y'all know what the bare minimum of things is. Bare minimum. Go ahead.
And so that doesn't mean like, going for a leisure walk, right? That means like getting your heart rate up. Like I tell patients, if you can have a conversation while you're exercising, you're not exercising.
Okay.
Right? You should be getting after it, so to speak. Preferably sweating. Your heart rate should go up into the sort of cardio zone. But if you did at least 30 minutes 5 times a week, that would be the bare minimum, and that would maintain health. But if you're looking to build health or recover from a sense of unhealth, I would try to do more, but build up to it.
Okay. So other than increasing your exercise, what's another lifestyle change that men, especially men that are heading into their 40s and their 50s, we all know that we start to become a little sedentary. We sit a lot more, we lay down a lot more, we take more naps, we probably eat a whole lot more. We're just not as active as our younger selves once were. So what are some dramatic, small but significant lifestyle changes that somebody can make that would have like a really great, impact on heart health?
I think maintaining like muscle mass is very important. I think weight training is also very important. It has a lot to do with your level of mobility. The more muscle mass you have, the more likely you are to be mobile into your aged years. So I definitely recommend, like, if someone wanted to lift and do more weight training and strength training, it has positive effects on bone density, has positive effects on mobility and also cardiovascular health. So that's another lifestyle change. I would try to eliminate stress. That's a hard one to do.
That is a hard one to do because stress. So stress, you would say that stress is, or would you say stress is the basis for the onset of the early markers of heart disease, which is high blood pressure, hypertension. Am I on the right track here?
So stress can certainly have an effect on hypertension. Like high blood pressure can come from a lot of things, like salt sensitivity. Like as we, certain particular ethnic groups have higher salt sensitivity than others. African Americans are known to have higher levels of salt sensitivity. But things like stress can cause blood pressure. Things like atherosclerosis can or plaque deposits can make arteries stiffer and less pliable and cause higher than normal blood pressures. So hypertension is one of those things that has a lot of um, sort of potential causes. Weight. So,
Mhm.
for example, if I pack on a lot of unhealthy weight, I'm more likely to have high blood pressure.
Mhm.
Um, so, elevated weight, being overweight, which is defined as a BMI over 25, or obese, BMI over 30, you're more likely to develop hypertension. Diabetes.
I was gonna ask you about the correlation, the relationship between cardiovascular disease and diabetes, specifically type 2 diabetes, which is something that isn't necessarily genetic. It's something that you can develop based on poor, lifestyle and eating habits, correct?
Sure, sure. And I diabetes has a very we consider diabetes mellitus, or type 2 diabetes, um, uh,
A precursor?
a coronary risk equivalent. So when I see somebody that has diabetes, I think of them as having heart disease.
Wow.
Like it's the relationship and the correlation is that strong. So if I have somebody that comes in and they're a diabetic and they're telling me, hey, everything's fine. I don't have any symptoms. I'm pretty active and I'm doing okay. I'm more likely to screen that patient than I am a patient who's not a diabetic and who's doing well and has a lower risk factor profile.
Mhm.
Because I assume that every diabetic patient has coronary disease until they've proven to me otherwise.
Mhm.
Um, just because the correlation is so strong.
Mhm.
The other thing is that diabetes, um, is sort of this quasi-inflammatory state as well.
Yeah.
And so it leads to plaque destabilization and more plaque rupture or heart attacks than people who don't have diabetes. So I treat diabetic patients very aggressively.
Okay. And you give them the same advice, when it comes to lifestyle changes and eating healthily, because once once you get type 2 diabetes, that's not like a kind of like a lifelong prison sentence. You can actually reverse it, correct?
You can with significant weight loss, diet and lifestyle changes. Yep, and we see a lot of this with you know um, significant weight reduction that has happened now with um,
GLP-1s.
the GLP-1 drugs and also bariatric surgery. Like,
Mhm.
so I've seen patients undergo bariatric surgery, have significant weight loss, and reverse diabetes.
What's your thoughts on GLP-1s? Because there's a lot of chatter about it. It's kind of becoming stigmatized. Um, uh, for whatever reasons, I don't really kind of understand it, because the majority of people that I know, and I've taken GLP-1s. I took
Mm.
semaglutide last year. I took
Okay.
it for about 2 months, and I was kind of blown away by the fact that every single bad craving seemed to disappear. I no longer craved alcohol. I didn't crave sugar. I didn't really crave salt. I actually craved eating healthy. I already did, but I needed salad. Like, I needed like super healthy food, and just all the stuff. Like, I would look at a steak and I would just be like,
Yeah,
I can
not for me.
pass. I
Yeah.
just really wanted something that wasn't going to be like super saturated in fat and that sort of thing. The other thing is that I started to feel was less ache and pain in my joints. My A1C dropped. I just really saw like an enormous amount of benefit to taking this. You have to be careful with it,
Sure.
obviously. You have to have a plan with your health practitioner as to how long you're going to be on it and what the plan is, because
Right.
if you don't work out with it, then you'll lose a lot of muscle mass. Again, I want to ask you, what are your thoughts on GLP-1s and the stigma that's associated with them versus the health benefits that you've seen,
I've
patients
seen.
experience?
So great question. So I don't I don't prescribe them cosmetically. And
Mhm.
so I like if somebody says, "Hey, I have a little
Well,
pudge
you're not
there,"
in
I
LA,
right,
because that's where it's prescribed cosmetically for
correct.
sure.
So I think there are better ways for that type of a patient. I think there are better ways to kind of manage, um, you know, uh, early insulin resistance, weight gain. Like diet and lifestyle should be really tried.
Let me tell you something about us perimenopausal women, okay? The weight wants to just
Right.
stick. It don't want to go nowhere, okay? And maybe that's a little bit of vanity, but also, who wants to carry weight around your trunk? I mean, that's, you don't want the weight around your organs and stuff like that.
No,
So,
understood. And so I think they have a role. Like
yeah.
so I and there was a time where we couldn't prescribe them for diabetics because they were so, ubiquitously used, and we were having shortages. So, I do think they can be sort of overprescribed in a way, but I think they are very useful in patients who have significant coronary and cardiovascular risk. There's a ton of data emerging showing reduced endpoints, less heart attacks, less strokes, less cardiovascular events with people who are on these drugs and have high risk factor profile, like, or high risk profiles, who've had heart disease before, have had a cardiac event before. Now, whether that's because of the weight loss they promote or whether that's a direct drug effect, I think the jury's a little still out. I mean, there's some people who are more convinced in my college than me, but I also think these types of benefits can be achieved with diet and lifestyle.
Absolutely.
Yeah.
I think that you should do both. But that's the thing that I noticed with it is how much you are just kind of like physiologically inclined to eat better on
Mhm.
it. Like literally your cravings for all the
Yeah.
bad stuff just go out the window. It was wild.
Yeah.
So I think it's like I think it's both things at the same time,
100%.
you know. Um so I want to divert because we were talking earlier about blocked arteries and how arteries are all over our body. One thing that I learned recently is that erectile dysfunction can be a manifestation of heart disease.
Absolutely.
I had no idea. I think the vast majority of people think that ED is caused by low testosterone, which it can be obviously.
It can be. Yeah.
It could be a psychological issue.
Sure.
However, it can also be as a result of a blocked artery in a man's penis.
That is correct.
And that is
Poor,
wild to
and
me.
poor circulation. And so, so I, in my practice, when I have particularly younger patients, I mean, every man who comes in and endorses or tells me that they have difficulty with, erections, I immediately think heart disease, and I redouble my efforts and kind of asking myself, have I appropriately screened this person? Do I have an appropriate idea of where they fit? And am I doing everything to reduce their risk?
Is that because you're a cardiologist that's your immediate thinking?
It is.
So, in the instance of a guy who's, having difficult, kind of getting the bull up, he goes to his GP.
Right.
What what's the percentage rate that the GP will think cardiovascular versus low testosterone and might overlook a blocked artery in that man's penis and it becomes a larger issue?
I would say that the vast majority of primary doctors and internists would would know that this is something to be concerned about. In fact, I get a lot of referrals. Like the referral to the cardiologist for the first time is ED, and that's also considered a vascular risk equivalent.
Are you
So
seeing
just
that
like
a
that.
lot more recently? Because I'm
Um,
hearing that ED is on the rise. I don't know. I'm not in these dating streets anymore. I can't be bothered, but I'm hearing
well,
that it's on the rise. Pun intended.
well, what I would say is I don't know if it's on the rise or not, but I would say I definitely see it. It's common. Sometimes, like you said, it's vasculogenic because of like blocked vascular arteries. Sometimes it's neurogenic because of a nerve problem. Like you could have prostate issues that are causing nerve issues and affecting erections. You can have hormonal issues like testosterone deficiency, or you can have psychological issues or psychogenic issues that you just have sort of hesitancy or anxiety about sexual intercourse or performance, and so those things can affect your erections as well. So it's hard to sort of say it's only cardiovascular, but that red flag should go up, and it should, like, so for example, my practice is for every, if you came into my office and you're a 35-year-old man and you were referred for ED, I'm getting a calcium score. performing cardiovascular risk assessments to try to understand.
Because that's not normal.
That is, well, it raises some red flags. It makes me wonder if there is a problem with blood flow. Is there a circulation issue that's contributing? But I also don't reflexively manage these patients by myself. Like I get them to a urologist. Like I think ED should be considered, sort of a multi-specialty kind of problem, and we all.
Of course, like call all hands on deck when a guy's, little pee-pee ain't working. All hands on deck.
Well, there are a lot of other diseases that should be considered that way as well, including but not limited to menopause, right?
Right, exactly. Okay.
But I would say yes. If I see particularly a younger man, and this is when I screen younger men who otherwise would be healthy. They come in, they play a sport, they're healthy, they're active, they're not having any symptoms, but they're having ED. I'm thinking, am I missing underlying coronary disease? And so there's a very well-known and well-established connection between erectile dysfunction and vascular disease in general. And so, cardiologists or vascular disease specialists, and we're kind of looking for vascular disease in a bunch of places. Like, I do feet exam. Like I check my patients' pulses. I look at, I ask them if they have any issues with ulcerations on their feet, and I listen to their necks and make sure they're not having signs of turbulent or abnormal blood flow in the neck. So I think part of a cardiovascular exam is a comprehensive assessment of, does this person have vascular disease and am I missing it? Because it can manifest in many ways. Sometimes people have bad blood flow to the legs and they end up with amputations when they don't necessarily need to. So it isn't always the heart. So my daughter's 16th birthday, no, it was her 15th birthday party. We went to Cheesecake Factory of all places, right? And
I love the Cheesecake Factory.
I love it, but the food is not very healthy, right?
Oh yeah, no, yeah, because it's saucy.
Exactly.
Mad saucy, like steak Diane. That's my shit. Okay.
So I had like some very fatty meal, and then we had red velvet cake, and I had a glass of wine, and I was driving back home, and I usually don't like when my wife drives because she doesn't see well at night, and so it's like a kind of I just don't want all of us to die.
Yeah.
So so I'm driving on the highway, and I can't get comfortable, and she's like, and I'm like, you want to drive? And she's like, you want me to drive? And she's like, something's wrong. And so of course I'm minimizing symptoms, and I'm like, and then I put the seat down, I lay down, I'm like tossing and turning, I can't get comfortable.
What were you feeling? Were you just feeling stuffed?
I was having back pain.
Okay.
So I was having really bad back pain. And it felt like if you ever had a bad workout, like, oh, you overdid it in a workout, you have like a tight muscle or something. That's how it felt. But it felt worse in that you could never soothe it. And it only got worse. It kept getting worse and worse. And so finally I got home that night, and after my wife drove home, and
y'all lived.
We lived, and I went to bed, and I woke up multiple times during the night, just couldn't get comfortable. Then I was on my way to work, and my wife was like, why don't you just call out? And I was like, well, I got patients and this and that. I never like call out of work. So she's like, you never call out, you're allowed to be sick, blah, blah. I'm like, I'm fine, I'm not sick. So then I'm driving into work after she told me to call out, and I'm complaining about the back pain again. And she's like, do not come home if you don't get seen. And I was like, leave me alone, kind of just like fighting, like arguing back with her. And finally she's like, no, I'm serious, don't come home. I'm not gonna let you in. And so I stop in the ER. One of my colleagues has me draw blood. I'm like, you know what, just draw blood, make sure everything's okay. I didn't know, but maybe I have an infection of some sort or something like that. I said, so we drew blood, and I went and started working. He called me back down. He said, your liver enzymes are up and your amylase and lipase are up, right? And I was like, those are like enzymes that go up when you have like gallstones.
Okay.
And so I had an impacted gallstone that was causing me to digest my own pancreas. So I was having something called pancreatitis, which can be fatal, all right? And so after he sees that, he calls me back downstairs. He's like, no, we got to get a CAT scan. I get a CAT scan. The radiologist who was reading the CAT scan calls me on my cell. He's like, are you in the ER? And I'm like, yeah. He's like, you
need to put the scalpel down and get on the table.
Your pancreas is inflamed, right? And he's like telling me all this, and finally, I ended up admitted to the hospital for over a week, getting IV fluids and morphine to control the pain. I eventually then had to have my gallbladder taken out. but this could have been like and I'm a doctor. I know what I'm supposed to
You're a
do.
doctor and a
I'm
man.
trained, but I
Uh-huh.
still did the same wrong thing.
Mhm.
And so I use that in my practice because it's like helped me become a better doctor. Because now, like when people tell me things, I kind of assume that they're maybe minimizing things. So I try to ask questions in multiple ways and get to the truth. Because what I find is patients don't always tell you the truth, especially, I agree with you, men tend to do this more than women. Women tend to be more forthcoming with their symptoms, whereas
Mhm.
men, like I had another patient who was, we have a walk-in clinic and he's like a construction type, so
Super machismo.
exactly. And
Mhm.
so when he came in, he was like, he was mad about waiting. He was like, I'm fine. He kept saying, I'm fine, but I have this issue, and he's like telling me these symptoms, but every time he gets the symptom out, he says, I'm fine. I need to go back to work, right? And the nurse practitioner who I was working with saw him and said, well, I think we could probably do an outpatient workup. And I was like, well, something's strange. Why did he come here today? And I was like, where was he going? He was going to work. He was driving along the highway and he pulled into our walk-in clinic. Why today? And when I got him to answer that question honestly, I was like, look, I know something's different, right? You drive past this highway a few times a day. You never stopped here. Why'd you stop here today? It's like, well, doc, it's really tight in my chest. We sent
He was
this,
2 seconds away from having a heart attack,
he
wasn't
was
he?
having a heart attack.
Okay.
He was 100% having a heart attack. We sent him to the ER. He got blood work. It identified his heart attack. He got a heart catheterization. It showed multiple blockages. He ended up with a bypass, three vessel bypass. I see him today. I
Is
see
that what's called a triple bypass?
triple bypass.
Triple
Yep.
bypass, that sounds
Yep.
major.
Yeah.
Mhm.
And he was having what we call unstable angina. He was having an active heart attack and was
Mhm.
minimizing it. And I see him now, and he's a new patient. He comes in with everything. He's like, Doc, I'm having this problem. I did a stress test on him 2 weeks ago. Like
Mhm.
he's feeling well and doing well, but um, we tend to do this. Like, and I'll be honest with you, when I had my symptoms, I kind of felt like
No big
no
deal.
big deal. Like, we have aches, like you said, we have aches and pains all the time. But I think having the mindset of just having an objective person look at your symptom complex is really important.
Mhm.
And we all are susceptible to that, like, but men more so, in my opinion, than women.
Mhm.
But but I think that's why like doctors shouldn't treat their family because I think you can lose objectivity. And sometimes you need a fresh set of eyes to look at something and say, hey, well, this little clue here, did anybody look at this? And and I think that's what really good care is about. But you have to first present. And I think there are a lot of barriers to why people don't present, right? They have like, maybe that guy didn't want to come in that day because he had to go to work.
I think part of the reasons, I can only speculate as to the reasons why a lot of men avoid going to the doctor and also avoid addressing the onset of symptoms. I think some of those reasons might be cultural. They don't want to be a burden. They feel like if they don't go to work and, they're the providers, then the whole household is going to fall apart. I think a lot of men feel like, I don't know, it's such a strange thing that they think that nobody really actually cares about them, and so they stay away from the doctor. I think that there's also fear in finding out because they know that they have been ignoring symptoms for a really long time. Actually, when I had an oncologist on last season, when we were talking about colon cancer, he said the like one of the main reasons why men end up passing away from colon cancer is because they discover it in stage 4. It's stage 1, stage 2, even stage 3. You have a much more significant chance of curing it
Yep.
and living a long, healthy life. But once you get to stage 4, it's, kind of like a foregone conclusion. But that was a whole lot of symptoms that they ignored along the way.
Right. And
So I think that I'm guessing that you see this a lot.
yeah, I do. I see people neglect care for, we call this like social determinants of health. Sometimes it's economic reasons, sometimes it's cultural reasons, other times it's machismo, right?
Mhm.
But
Which can be
and
cultural as
cultural
well.
too, yeah. But it is it is a barrier to seeking care, and it's one that like doctors are very sort of cognizant of. We're tested on exams about like some of these things that we might not this is not the nuts and bolts of the science, but this is about giving and delivering good care, and sometimes understanding people and what might cause them to sort of not be as forthcoming or or not comply with the therapies that you give them. Um, an example of this is I can think of a patient who I took care of for high blood pressure and cardiovascular risk. I They were also having some symptoms of fluttering heartbeats, and so I started them on a medicine, um, among other medicines to lower blood pressure that is called a beta blocker. And that medicine was one of the three medicines he was on, but that medicine was causing him some issues. Um,
ED.
ED,
Mm.
erectile dysfunction. He never let anyone know. He just stopped taking his medicines. I found out because his wife called me one day, um, and the message got to me. I called her back, and she said he's not feeling half of his body. And I said, hang up the phone, call 911, and have him immediately go to the emergency department. And when he did, luckily, he went to a center that was neuro capable, and they could do. He had what's called a neurointerventional procedure to treat a stroke. He was having an acute stroke, and he over time did well. But when we did a postmortem and I asked him what happened, he said I stopped taking any of my blood pressure medicines.
See, look
Instead
what
of just
happens when you guys stop taking your medication and stop adhering to your doctor's count. Look what happens. So men seem to argue this point a lot. There's this statistic that um, men are healthier and live longer lives when they're married versus their single counterparts, and single women live longer, healthier lives than their married counterparts.
wow.
Can you speak to that being truth or
I've
fiction?
I've definitely heard about the married men thing, and
Mhm.
in the analysis, because I remember looking at this paper, and in the analysis essentially it was that wives were compelling their husbands to go in and be seen, and
Yeah.
that was the sort of the gist of the.
Well, like your wife did. She was like, you cannot come home until you go and get this whole
I'm living
situation
proof of
checked
this.
out. You're literally living proof of
Right,
it.
I'm living proof of it.
Yeah, and I literally just saw a girlfriend of mine. She just had her gallbladder removed. She's got two very young children at home. She's having a massive psoriasis outbreak all over her skin, her hair. It's falling out. Her husband looks just fine, but she's literally falling apart. And this is what happens. Women are so concerned with the family and taking care of their children and their husbands that they let their care fall apart, and husbands are just kind of like on the benefactory end of their wives' care.
Yeah, I see some truth in that.
Yeah.
I'm lucky in that I have, like, my wife is in healthcare as well, so she kind of saw signs that were concerning and had the objective mindset to say something's wrong. So I
Mhm.
was lucky in that respect. But I think even for those who don't have wives in healthcare, I think just knowing when somebody's different, when somebody's not behaving themselves. A lot of times when I am not getting a clear story from a patient, I will have them call their wife or their significant other.
That's one
Or
way to do it.
I do that all the time. Or
Okay.
when I'm having problems with compliance,
Mhm.
I
Call the
tell people
wife.
I'm telling your wife or I'm telling your husband, and that's a really useful tool because I think you know being someone's doctor is about sort of developing a level of trust and developing a relationship with them. And that's not always the easy thing to do in this fast-paced world. If we have telehealth visits and we have, text, text message sort of questions that we answer back and forth, and sometimes, and we have like sort of mid-level providers who will see a patient when I'm not available to see a patient. So sometimes I might see somebody this year, and then the next time I see them is 2 years from now if they're not very active.
Mhm.
And so sometimes it's hard to get a good, you know, develop a good doctor-patient relationship in that kind of an environment. Like
Mhm.
the system is becoming increasingly stressed.
Yeah.
But
Yeah, one of my questions was going to be, how to teach men how to advocate for themselves or, kind of like empower them. But I don't really feel like that's their problem. You know, women have that problem. Women have the problem of advocating for self and it falling on deaf ears and being gaslit. So, you know, we have to take, certain measures as it relates to how to advocate for self, analyzing if we are sitting with the right health practitioner or maybe, finding somebody else who's more apt to listen to our concerns. Where men, it's just kind of getting them in the door,
Yeah,
you
yeah,
know,
I've found that to be the case.
like how do you scare them straight?
Uh, like I said, with those two,
Usually, but why does it take such a massive event for men to be scared straight? You know, like what's the fix? At least the band-aid.
yeah, that's a tough question. I don't know an easy fix, for
Mhm.
that. I think that definitely involving the larger community, um, asking them, do they have someone who helps them make medical decisions, like trying to get a sense of who they are, developing a better, um, uh, more intimate relationship with patients, I think is always a good thing.
Mhm.
Sometimes you do that by asking them what they do for work or, what they did this past weekend. And sometimes when people feel more comfortable with you, and you humanize that interaction a little more, it's less sanitized, like it's more humanized.
Mhm.
I think people are more apt to open up to you.
Yeah.
That's been my experience.
Mhm.
Um, but I don't know how to, I think it's definitely a culture change. That's why one of the reasons why I'm doing this podcast, because I I really think that being able to have people access the information in a medium that they feel more comfortable with.
Mhm.
Turning on a podcast in the privacy of your own home is a lot easier than coming to the doctor's office,
It is.
right?
Mhm.
So, and this information should be shared, right?
Yeah.
Like, and if it gets one person to come in when they're having symptoms and maybe ignoring it,
Then we won.
then we won.
That's the most rewarding part about doing the show. I should have asked you this a little bit earlier, but what role does family history and genetics play in heart health or cardiovascular disease?
Plays a huge role, and one that we're increasingly recognizing. You know, there are definitely like single gene defects that we've seen as cause of arrhythmia or as causes of sudden death type syndromes. We're increasingly recognizing the role of genetics in weakening of the heart. Like
Mhm.
there now, when I have patients with weakened heart muscles, I look for all types of genetic sort of predispositions. Um, there's also a role for genetics in early heart disease development, and from the standpoint of having both high cholesterol, um, from the standpoint of having a propensity to clot, there's certain genetic conditions that make people more likely to clot, and hence more likely to develop cardiac and vascular clotting disorders. Um, so, I mean, we see this in every facet of we see genetic predispositions in rhythm disorders like AFib, atrial fibrillation. We see genetic predispositions to some types of valve diseases, and certainly congenital problems.
Mhm.
So, there's definitely a role for genetics and heart disease. That's why, and part of any good history is
Mhm.
taking a family history, right?
Well, let me ask you this. There's some situations where somebody cannot find out what their family history is because maybe they were adopted and they don't know their biological parents, or somebody like me whose parents are both passed. My
Mhm.
father passed when I was 15 years old. It's a blur as to what really actually happened to him, and now I can't really ask anybody because my mom has passed away.
Sure.
I didn't know 3 out of my 4 grandparents because they were dead.
Right.
And my grandfather, he passed away when I was 14 years old.
Wow.
And I think it was from a heart event, but I just was too young to know this. So, in the circumstance in which somebody doesn't have access to knowing specifically, oh, mom had this, dad had this, uncle has this, et cetera, what's something that they can do? What's some kind of genetic testing that they can do to find to develop some level of a history?
So that's a good question. So we're getting better and better at having like genetic tests that we can run on people, but right now it's not like you go into the cardiologist office and you get a genetic profile.
Mhm.
That's we're not sort of there yet, but there are some things that when we're suspicious of, like a weakened heart or a rhythm problem, sometimes we look at your EKG just from a regular well visit. Like I've had people referred to me, 26 years old, 25 years old, and the the referral is for abnormal EKG, and
Mhm.
the abnormality is something that has a genetic predisposition.
Mhm.
And so I see it and I go, wow, this person may need some further testing and sometimes even genetic testing. The tricky part about genetic testing is um, depending on the disease entity, like you have to consider what will one do with the results.
Mhm.
If it doesn't really impact therapy and it doesn't necessarily inform notifying, sort of family members, then, we have to approach it sort of not with a one size fits all kind of pattern. And so
Mhm.
in that case, if somebody has, like, for example, thickened heart wall muscles, and I think they have a genetic reason for it, I'll oftentimes have them go to our genetic counselors and talk to them about what this means, because that's a whole nother
Yeah.
piece of it. It's like, if you have a genetic predisposition to something, you may need some help interpreting what this means for me moving forward with having kids, or with telling my, my siblings or
Mhm.
significant other, et cetera, et cetera. So
So you've been out of these dating streets for a long time, Doc. So let me tell you what's going on. There's something called a male loneliness epidemic.
oh boy.
And, you know, there's a lot of speculation as to why it's arrived, why it's here, what are the causations of it and whatever else. But it got me thinking about something that I'd heard a long time ago called broken heart syndrome. Can you tell us a little bit about what broken heart syndrome is, and in layman's terms what it actually means, and like one of the major causes of it?
Sure, sure. So, broken heart syndrome is sort of a entity that we saw probably about, we started recognizing more probably about 20 years ago, and we started you started seeing more case reports of it, but it's probably been around much, much longer than that. We've just started describing it a lot better. But essentially, what it is, it's when your heart becomes weakened, usually transiently. So the heart muscle
What
squeeze.
does that mean, transiently?
Transiently means for short term. I'm
Okay.
sorry. So uh, basically, your heart muscle can get weakened because of damage to the heart muscle from, you know, direct trauma or a virus. Most of the time, it's from blocked arteries,
Mhm.
suddenly blocked arteries, like in a heart attack, but it can be from chronically blocked arteries too. But what happens is when your heart muscle gets damaged, usually it's irreversible, especially if it's scarred and it's not, you don't catch it quickly,
Mhm.
right? And so broken heart syndrome is when we see this pattern of heart weakening, but we don't see blood flow issues to explain it. And usually there is a um, antecedent or preceding emotional event,
So
like
stress.
stress
Okay.
or loss of a loved one. So that's why we kind of named it broken heart syndrome, because we sometimes saw it in like widowers or
Mhm.
people who just lost a significant, like, I've seen it one time in someone who had a dog die,
Mhm.
right?
I mean,
Yeah,
listen, I didn't want to talk about if something happened to my dog.
right. It's
I would be inconsolable. Don't talk to me for about a year.
right.
Yeah.
So we see this, and it's usually what we think is happening, and there's pretty good data on this, but I don't think it's totally settled. But we think is happening is that this surge of catecholamines, or stress hormones. These are like hormones that your body releases when they're stressed. They all have vasoactive properties. So basically, they make the vessels that supply blood to your heart muscle. They can make them contract and
Hmm.
constrict,
Hmm.
and if they constrict very tightly, they can block blood flow.
Hmm.
So whether you have blocked blood flow from a vessel that constricted, or whether you have blocked blood flow from a plaque that popped in your heart doesn't know the difference.
Is that what happens when you, I don't know, I've had a breakup that was so severe that it felt like my heart hurt. My literal heart hurt. Is that what was happening? Is
It
like
could
stress was creating, like making the vessels constrict?
it could have been 100%, like that. That
Wild.
is that is that is, and we see this, by the way, in panic disorder. So there are some people that have such severe panic disorder that when they get very anxious or very stressed, they'll have chest pain.
Mhm.
All right. It doesn't always mean that they have a blocked artery. Sometimes it means that they had a limitation of blood flow for this reason.
Mhm.
It's a really hard entity to sort of nail down because sometimes when people come in, we look for blocked arteries. We don't see anything. We say, oh, you're fine.
Yeah.
But understanding what is happening around
That
the
person's life.
symptoms and
Yeah.
around their life is really important because it can
Mhm.
kind of help you make a diagnosis.
So, yeah, men and women seem to handle stress differently and deal with stress differently. Women seem to be a little bit more inclined to be proactive about stress management. They start doing things like yoga, Pilates. They just start to identify very quickly what's causing them stress,
Right.
how it can be addressed if that can be removed, and what will make them feel better, if that is, meditation, whatever the case is. But for men, I don't think that men by and large seem to understand just how deadly stress is.
Correct. This goes back to, I mean, and that's been my
And
experience with
also
a lot of
it
my
can be like
friends
a
too. Yeah.
cultural, thing. So
Yeah.
what would be your advice to men in terms of stress management
Well,
and how important it really actually is?
super important.
I mean, maybe we can create an analogy like using a car, maybe that will help y'all out. So stress car
So,
management.
so stress management is definitely important. I would approach it like I can only talk about what's worked for myself and other men that I know, and I know a lot of men who work out. I think working out and physical exercise is a good stress relieving tool. Um, you know, I really believe in the power and utility of therapy, and I think it's underutilized. I think um, there's stigma within many communities and particularly among men about therapy, and I think that's something that shouldn't be. Like we should look at ways to kind of how we get men to be more open about that. I don't know easy
That
answers.
that is a pickle. I don't
Yeah.
I know men that literally say I don't believe in therapy. I'm just like, "Eh, it's not like Snuffleupagus. You know what
Mhm.
I'm saying? It's not like an imaginary creature. It exists. Like you can't say you don't believe. I guess it's almost like a religion. You know what I'm saying? Like trying to tell an atheist, to believe in God.
Right. Well, I would say that the mind has definite relation to our health and understanding the sort of the understanding the psychosocial um, stresses that are affecting your body is important. And I think that like trying to get men to do that
Is an
is not
exercise in futility
is not
sometimes.
an is not an easy thing always, but
Mhm.
I think it just comes from a lack of understanding. Like I think if you have a loved one, like if for the couples watching the show, if you have a loved one and you're concerned about them, maybe go to the doctor with them if they're having like some concerning mental health issues or stress related issues because it can affect their physical health,
Was
particularly
there
their heart health.
Was there a pivotal moment for you where, you had a light bulb moment as it related to therapy being a stress reliever?
Uh, I've personally used therapy, like family therapy. I've had some. I've teenage daughter who life can be stressful with at times, and
You don't
I
say.
couldn't
I was
under
one at one
I,
point.
I
I
couldn't
was hell on
understand.
wheels.
Right, I couldn't understand how to communicate with her and get her to see things that I was trying to explain to her, and it was very helpful for us. I got to understand things that my daughter was concerned about that I didn't really you know, even think was an issue, right? So, I think if you've had an experience with therapy and it's helped you in that way, then you'll be more inclined to use it. But I can see why you say men tend to be not very.
I think it's just so weird, because, just my therapy journey, you know, I guess self-discovery is intimidating, maybe. And also accountability also might be really intimidating. But I don't know. I feel like this is our life's purpose, or at least one of them, is to kind of just constantly evolve, until the day we leave this, this husk behind and enter the spirit realm again. I think that that's one of our purposes is to constantly evolve, and you can't do that without, just like the just being on that path of self-discovery and self-aware that's just self-development.
I couldn't agree more. But and to your point, like with the whole, men not seeking therapy, I think it's a feature of just um like being because for example, in healthcare, doctors deal with a lot of stress and get a lot of unloading from other people. And I talk to many physician colleagues who are like, by the end of a day of hearing everybody's problems, it's really challenging, right?
Don't
And
they? So
so
wouldn't that like automatically, drive them towards seeking their own, you know?
you would think it would, but
Mhm.
I actually think more physicians should probably have therapy. The problem with therapy is that it's not it's not as promoted amongst our profession as it probably should be.
That's
Right.
wildly
It
ironic.
really is not. Like it's a function of, therapy takes time, and time is not something that many doctors have an abundance of, right?
Mhm.
And so you have to really be committed to it and understand the benefits of it to really, engage in it. But I agree with you. I think it's valuable, and I think it's really important to overall heart health.
All right, doc, I know that we've been talking about like some serious stuff, but now we do something called rapid fire.
Okay.
Okay, you don't have to like, break out into a sweat. It's really easy. It's just fun. I'm going to ask you like either or questions, and this is rapid fire, okay?
Got it. Got it.
When it comes to starting your day, which do you prefer, coffee or tea?
Definitely a coffee person.
Okay. Which is better for heart health, cardio or weight training?
Cardio.
Which one do you prefer to start your day with, coffee or tea?
Coffee.
Which is better for heart health, cardio or weight training?
Cardio.
If you had to pick just one, stethoscope or EKG machine?
EKG machine.
Where would you rather work, emergency room or private practice?
Private practice.
Which would you choose, save one life dramatically or improve 100 lives quietly?
Improve 100 lives quietly.
Come on, guy. You know who he was gonna say. Okay. Even though I would like to, save a baby in a runaway carriage and I don't know, cure cancer. But that's just me. All right. If someone could only commit to one, healthy diet or regular exercise?
I would say healthy diet.
Yeah.
Yeah,
Yeah.
healthy diet.
Abs are made in the kitchen. When are you at your best? Early mornings or late nights?
Early mornings. Yeah.
Which has a greater impact, medical breakthroughs or public health education?
Public health education.
You're really good at this. Most people are just like, I don't know, like, I can't choose. It's so hard. And people just really struggle with rapid fire. I'm like, it's just fine. What suits you? Stress-free job with lower pay or high stress with high reward?
High stress with high reward.
Oh. What matters more in the long run? Work-life balance or career legacy?
Early in my career, I would have said career legacy. Now I'd say work life balance.
That sounds like a wise man in
I'm
his 40s.
evolving.
You've evolved. Okay, good on you.
Yeah.
All right, that's it. Alan, thank you. Dr. Vaval, thank you so much for dropping by to talk to us. I hope you guys have gotten a lot out of this episode. For the men, this was specifically for you. So basically, reduce stress, stop eating crap, get into the gym, and be nice to your wife. That's that's basically the overarching themes of this episode. Again, Dr. Vaval, thank you so much for
Thank you for
joining
having
me.
me.
Absolutely. You're welcome back anytime. And thank you all for joining me on another episode of Hot and Bothered with Melyssa Ford. Take care. Thank you for tuning into Hot and Bothered with Melyssa Ford. Please rate, subscribe, and comment, and share wherever you get your favorite podcasts. This season of Hot and Bothered with Melyssa Ford is hosted, written, and executive produced by me for Forged Path Productions. This episode was written and produced by Sebastian Godin. Filming and editing of this episode is done by GVI Films
and executive produced by Rachel DeSalvo.